So hello everyone, and specifically good morning to Canada, Shannon. This is a brand new edition of the EuroELSO Webinar series, and it's a great honor to have Shannon Fernando here from the Lakeridge Health Corporation in Ottawa, who recently published some stunning data on age as a risk factor for outcome in ECMO. And as I said, it's great to have you here, Fernando, Shannon. Thank you for taking the time and sharing your expertise with us. And that's your stage. For our participants, please feel free to put on your questions anytime. In the webinar tool, I will collect them and pass them on to Shannon. And be aware that this is going to be recorded. So if you have to drop out and think this is an interesting session, you're welcome to come back in a couple of days. It's going to be online at the EuroELSO website. So Shannon, we're very much looking forward to your presentation.
Thank you so much, Peter. Thank you to EuroELSO for the invitation to present at this webinar. ELSO has played a major role in a lot of this research, so it's a real honor to be able to do this. I'm talking today about age and the association of outcomes after ECMO. And I'm curious to hear thoughts from many others, because as I embarked on this work, I think a lot of people would say, I'm probably not going to put a 90-year-old patient on ECMO. And I think that that's true, but I would also challenge you throughout this talk that the actual association is a lot more subtle than we think. And hopefully that will become clear as we discuss. Conflicts of interest that I should mention, the only one that's really relevant is I serve on the Advanced Life Support of the ALS Task Force for ILCOR. And therefore, I do play a role in the creation of treatment recommendations in cardiac arrest. I'm not going to be speaking a lot about eCPR, but I do have a role in that. And not really a conflict of interest, but just to point out that this discussion is really focused on ECMO and not other forms of extracorporeal life support, such as ECOR, or other forms of mechanical support. And that's relevant with the DANGER trial just published a few days ago, that I think more research is needed into how age and selection plays a role in these devices. Talking to a group of people today that have very good experience with ECMO, so I won't dwell too much on how it works, but suffice to say, as we all recognize, it provides cardiorespiratory support to patients who have failed quote unquote conventional methods. When we think of ECMO, of course, the three major indications I'll go through briefly. Perhaps the greatest evidence base for ECMO exists in the use of veno-venous ECMO for respiratory failure. Randomized evidence in severe acute respiratory distress syndrome, ARDS, supports the use of EV ECMO. Of course, the EOLIA trial led by Alain Combe and the subsequent Bayesian reanalysis led by Ewan Gallagher showed benefit of EV ECMO in patients with severe ARDS. This is subsequently substantiated by individual patient data meta-analyses. And you've seen in the last year, the ESICM and ATS guidelines, both making a recommendation or suggestion for the use of ECMO in patients with refractory hypoxemic respiratory failure. Less clear, of course, is the use of VA ECMO for cardiogenic shock. And I think this is where selection becomes important. The largest trial on the use of VA ECMO, of course, the ECLS shock led by Holger Thiel, showed no benefit of mortality. And the subsequent patient-level data meta-analysis, including ECMO CS and other randomized data, did not show benefit in the overall patient population in any of the subgroups, and did show an increase in bleeding and major complications. So the use of VA ECMO since the publication of ECL shock has not been incorporated into guidelines, but very likely it's very unlikely that the guidelines will recommend routine use, and that leads us very nicely to this talk. ECPR, which I'm not going to spend a lot of time on today, has had mixed results, as many of you know. The ARREST trial, although very small, seemed very promising with a very large mortality benefit. The Prague-OKA trial, led by Jan Belalavec, seemed to show a tendency towards benefit. The subsequent Bayesian analysis showed benefit. And then, of course, Inception, which was a purely negative trial last year out of the Netherlands. The meta-analysis, which I've shown here by Christopher Lowe and Dan Brody, does seem to show potential benefit, but this meta-analysis also includes observational data. For our part at ILCOR, our consensus on science and treatment recommendation, we do suggest ECPR for rescue in selected out-of-hospital cardiac arrest patients as a weak recommendation. Who those selected patients are leads us very nicely to this talk again. We also have to remember that ECMO comes with costs. And, again, with this audience, most of you are aware of the complications that occur after ECMO, mostly related to bleeding, hemorrhage, but also neurological complications, CNS infarct, circuit-related complications, cannula-related complications. The list goes on, and many patients who end up on ECMO will have at least one of these complications, and that's important to recognize. We did work in our group in Canada looking at costs associated with ECMO. This paper is a few years old now, but shows that the median inpatient cost of any patient receiving ECMO was about $90,000 Canadian, roughly about 60,000 euro, and this was in 2019. And it's a pretty substantial cost whether a patient lives or dies. Oftentimes, these patients will require interfacility transport, which is costly as well and associated with potential risks given the hub and spoke model that we employ of ECMO. And it may impact the care of other patients. For example, some centers that are not doing a lot of ECMO, for them to put a patient on, it will require, for example, cancellation of a cardiac operating room so as to use the resources, the perfusionist, to run an ECMO circuit. So that has costs and impacts on other patients as well. We also have to remember that long-term outcomes of ECMO are very, very poorly understood at this point. So, of course, the very landmark work led by Professor Carol Hodgson, the Excel study showing pretty significant disability at 6 months after ECMO, and then work from our group published 2 years ago now in JAMA, looking at new mental health diagnoses in survivors after ECMO. These patients experience significant morbidity. Of course, survival is important, and we all recognize that survival is important, but long-term outcomes do matter to patients and to caregivers, and we are just really scratching the surface of this in the ECLS literature. So that leads us then to where I think ECMO research is going, and that is not, does it work? Because it seems to work in some people, but who are those people? Who are those selected people that it works in? And of course, we're talking then about the idea of precision medicine, the idea that not all patients are equal, that for any given treatment in a trial, you're given an average treatment effect in that trial, but there are patients within that trial that benefited, there are patients that experienced no benefit, and there are patients that potentially may have been harmed. And it's therefore very important to understand the heterogeneity of treatment effect and optimization of selection in patients for any treatment, but particularly ECMO, given the costs that we talked about. And so there's been a lot of work already done in the world of prognostication for ECMO, and I have to give a lot of credit, as many do, to Matthew Schmidt here. This work is now almost 10 years old, but very cutting edge, using very advanced data sets and very advanced methods to develop prognostic scores for patients receiving VV ECMO, the RESP score, published in 2014, and then patients receiving VA ECMO for cardiogenic shock, the SAVE score, published in 2015. And I've shown you there the RESP score on the right-hand side, as many of you are familiar with. Interestingly, for the purpose of this talk, you can see age is categorized into 3 categories: 18 to 49, 50 to 59, and then greater than 60. And you can see that the age component, the score of it, is equivalent to other things such as duration of mechanical ventilation. It's equivalent to the PaCO2, for example. It's weighed roughly the same as that. And the question becomes how much of an emphasis should age play? And we're going to talk about that. But you can see that the lower the RESP score, the lower the likelihood of survival for VV ECMO. And that was really, really important work led by Matthew almost 10 years ago now. Unfortunately, these tools have not really translated into a strong validity or prognostic performance. So this meta-analysis published in ICM last year looked at prognostic risk scores for prediction of mortality after ECMO, and specifically looked at the SAVE and the RESP score, since these are 2 of the best tools, and specifically looked only at cohorts that tried to externally validate these tools. So they didn't look at the initial derivation models. And what they found was, unfortunately, these tools only have moderate predictive performance. So you can see the C statistic, or the area under the receiver operating characteristic curve, of 0.66 to 0.7. That would, squarely about moderate to low prognostic performance. You really want scales to be at least 0.8 or higher. And so therefore, it's questionable about how accurate these tools are when we try to apply them at the bedside, when we're trying to select patients for ECMO. So it leads us back then to that same question of how then do we select the best candidates for ECMO? And I would challenge you that to do this, we need to go back to the drawing board. We need to look again at the factors that we are currently using, because I know many of us are using factors. Many institutions have criteria by which they select these patients, and really go back and inform ourselves on what are the best prognostic factors or the worst prognostic factors for outcome after ECMO. And that leads us then to age and outcomes after critical illness. Age plays a role in outcomes in almost any disease process in medicine, and we all recognize and understand that, particularly true in critical illness. The older you are, the less likely you are to survive from critical illness. This is also important because worldwide, the population is aging, some countries more than others, and therefore there is an expected bolus of patients that are older and over the age of 65. These patients are becoming more common and will likely represent the bulk of critically ill patients as time goes forward. Unfortunately, understanding data on the age and the association with outcomes after ECMO, there's very minimal data that helps us understand. And this is a great example of how the data is currently categorized. So this is work from our group led by Alex Strand, who's an intensivist in Ottawa, and Eddie Fan and Dan Brody, looking at systematic review, looking at prognostic factors for survival after VV ECMO for COVID-19. And Alex found 11 different studies that looked at that, and he compares the unadjusted odds ratios, the adjusted odds ratios. But you can see that it's categorized as older age, quote unquote, older age. And that's because every study used a different cutoff. Many of these categorizations are arbitrary. And even though we believe age is an important factor, and it shows clearly here associated with worse outcome and mortality, it really, we need more nuance in how we look at that. So there's very little data that actually exists on the association between age and outcomes after ECMO. And most of the existing studies are actually small institutional cohorts, which provides the benefit of having a lot of great data, but also a relatively minimal number of patients, and the external validity of that is questionable. Most of these studies involve simple categorization or dichotomization. So they've chosen an arbitrary threshold, sometimes 65, sometimes 60, and then dichotomize these patients. But that includes the patient who's 30 and the patient who's technically 90. And so, this simple dichotomization doesn't hold forth It doesn't hold forth in a valid way. And despite this lack of data, I think most of us will agree that age is already incorporated into decisions around the provision of ECMO. I led this talk off by starting and saying, you're probably not going to put a 90-year-old on ECMO, and I think that's how most people feel. Some centers, including centers I've practiced at, have upper age limits which preclude ECMO. And this was certainly true during COVID-19 when resources were particularly limited, that some centers employed an age cutoff and felt that above a certain age, a patient was unlikely to benefit. But that was done in the absence of data demonstrating an association. So we need a more thoughtful investigation of the association between age and ECMO. What is the relationship exactly? How does this change across decades, from even as young as 30 years old? And is there a threshold of futility? Is there a point at which outcomes become so poor that ECMO is probably not indicated? So that led us to the sequence of studies using the EuroELSO Registry, looking at age and ECMO, which I will talk about, and I think is really the focus of this discussion. Our primary study team, the first two gentlemen there probably don't need an introduction to this audience, but Dan Brody and Graham McLaren really came up with the idea to study this, and I'm very grateful to them for trusting me to lead this work. Dan McIsaac is a colleague of mine from my training in Ottawa. He's an anesthesiologist and clinician scientist there, but he has very extensive background in training in statistics and performed himself all the statistical analyses, many of these models taking several days to run based on the size of the EuroELSO registry. And so I do not have, I don't think, the appropriate expertise to discuss the statistics around these studies in detail. And so I'll defer to Dan on most of that, but suffice to say he used very elegant methods to do this, and we'll go through them very briefly. And of course, none of this would have been possible without the EuroELSO Registry, so my gratitude, of course, to Joe Tona, Ram, and Mark Anders and everybody there for allowing us the opportunity to study this with their registry data. So this work was published, as Peter mentioned, in two studies, two sister publications in ICM. The paper on the left looking at veno-arterial ECMO published at the end of 2023, and just a couple of months ago, the sister paper on outcomes after veno-venous ECMO published in ICM in 2024. Because both studies use very similar methods, I'll sort of talk about them, and certainly if there are more questions about methods, we can discuss afterward. So we use data from the registry of patients 18 years of age or older. So in the VA cohort, there was 15,000 patients roughly. And in the VV cohort for severe respiratory failure, there was 27,000 patients, and that includes 6,500 patients who had respiratory failure due to COVID-19. We did study the COVID-19 group separately, although I won't be specifically presenting that data here. Suffice to say, it was the same as the rest of the veno-venous cohort. We evaluated the association between age and mortality, but also age and complications during ECMO. So these complications included the ones that are traditionally captured in the registry, including renal failure that required renal replacement therapy, ischemic stroke, intracerebral hemorrhage, DIC, various limb or mechanical complications. Importantly, in the production of the models, we collected data and included variables for each cohort. And obviously, these variables are different between the VA cohort and the VV cohort. So, of course, we accounted for age, for sex, for index year, for a comorbidity index, for BMI, things that are known to be associated with outcome. We also use pre-ECMO supportive therapies. So especially for the VV cohort, we counted for prone positioning, neuromuscular blockade, steroid use. And all of these variables, as per recommendations, were included in the models a priori. So we didn't base this on statistical testing or association of these variables with outcomes. They're based on what we believe is associated with outcome. And specifically, we used variables that arose before the patient was cannulated and put on ECMO. And that's really important because the time when you're making a decision on these patients for candidacy is at the time prior to cannulation. And so therefore, including variables that occurred after cannulation would not be appropriate in that model. And Dan applied Bayesian methods to estimate the association of age with outcomes, and he used logistic regression for all analyses. And like I said, each of these models took several days to run. And that speaks to not only the number of patients included in the model, but also the number of data points for each patient. I'll present the results here, and the VA cohort on the top, the VV cohort on the bottom. And if you just look at the first column being age, but the second column being hospital mortality with a weekly informative prior, and in Bayesian speak, that is basically to say without knowledge of any any context or pretext about outcomes. So how we traditionally conduct analyses, you can see that the odds ratio of mortality compared to the cohort of 18 to 29, which is the control group, increases as you age. And that's not surprising. What is surprising, perhaps, is how early this association arose. So in the VA cohort, no difference between the age 30 and 39, but at the age of 40 to 49, the odds ratio of 1.26, with a probability of greater than 99% of that being an odds ratio greater than 1, which basically says that as early as the age of 40, the odds ratio of mortality is higher than the patient who's 18 to 29. In the VV cohort, that emerges even earlier. So even the 30-year-old group in the VV cohort had an odds ratio of mortality higher than the group that was 18 to 29. And if you go across columns, you see the same when you're considering strongly informative prior. And our informative prior was basically the association of age with outcomes in critical illness. And then we also looked at complications, and you can see the same. So again, age very clearly associated with not just hospital mortality, but also complications as early as 30 or 40 years of age. These are the forest plots, which again, very striking in demonstrating how this increase occurs. In the VA cohort on the left, you can see again, as I mentioned, compared to 18 to 29, no difference 30 to 39, but then the differences emerge starting at the age of 40. The VV cohort, even more exaggerated and even more narrow confidence intervals, much narrower confidence intervals, starting at the age of 30 to 39, odds ratio of higher mortality compared to 18 to 29. So very striking data without an obvious clear sign of futility. Certainly, once you get to 80 and over on VV ECMO, the odds ratio is approaching 9 of mortality, which is pretty significant. But there were still patients that were greater than 80 who survived on VV ECMO. So there was no clear point at which futility was observed. Important limitations, I think, are necessary to point out in this study. So we had very limited granularity in patient variables. The ELSO registry is amazing in what it has, but there are important unmeasured confounders. So we didn't have, in particularly, severity of illness. There's an important bias that needs to be considered in any study that looks at patient age and outcomes, and that is, especially in critical illness, decisions related to withdrawal of life support are much more likely, unfortunately, to be made in patients who are older. So most of us are more likely to persist with treatment in a patient who's 30 compared to a patient who's 80, as an exaggerated example. And so those decisions around withdrawal of life support, as I think has been demonstrated in the research, are not always evidence-based or informed. And so older patients are at higher risk, and that could confound our analysis for sure. We tried to incorporate most important diagnoses. So that's certainly true in the cardiac cohort. In the respiratory cohort, because we were looking at hypoxemic respiratory failure, we excluded patients with asthma or COPD who presented with primarily hypercapnic respiratory failure. But capture of all of these diagnoses was done using ICD codes. And as many of you know, ICD codes are not perfect in their performance, to say the least. We didn't have data on long-term outcomes. As I mentioned, hospital mortality matters, and I don't think anybody disputes that. But there's a lot of increasing evidence that patients care as much, if not more, about long-term outcomes. And I think that's an important thing to understand. If you're 80 years old and you survive ECMO and you go home and you die within 5 days, I think that would matter to that patient and to that family to know that just because they survived the hospitalization, what their long-term outcomes might look like. And of course, really important to consider, just in prognostic modeling in general, is the registry, just like most databases or most cohorts, only includes the patients who received ECMO. So there's inherent selection bias, even among the elderly patients. You would think that selection bias would become more prevalent at older ages. You're probably going to be more discriminative in who you put on ECMO at the ages of 70 and 80 than at the age of 30. So that, if anything, would potentially bias us towards the null. But it's just important to recognize that because we don't have information on the patients who were, quote unquote, sort of left on the sidelines, we couldn't explore heterogeneity of treatment effect by age, which is an important question. Is VV ECMO more efficacious in an 80-year-old than it is in a 30-year-old? We can't really answer that from our data. So the two major take-home points from these two studies is that for patients receiving VA or VV ECMO, increasing age is significantly associated with poor outcomes, unsurprisingly. But very surprisingly, these associations emerge very early as 40 years of age in VA ECMO or 30 years of age in VV ECMO. And what that means is when future prognostic tools are developed on VA and VV ECMO, they really need to look at age or include age at all of these various cutoffs, knowing that the association with outcomes emerges that early. And importantly, there's no upper limit above which the provision of ECMO becomes futile. And that's important for institutions that have existing age cutoffs. This is a nice infographic that was created by ICM from the VA paper showing how mortality increases as you age and starting at age 40 to 49 compared to the patient who's 18 to 29. So very clearly shows increasing odds ratios even among younger patients. So I want to end by just sort of discussing why this might occur. And I think that's the big question. You know, it's not shocking that age is associated with outcomes, but why is it emerged so early, and why is there no obvious upper limit? And I think that because what we don't account for in a lot of these studies is this idea of biological age. But the truth is, when we're seeing a patient at the bedside, we often are accounting for biological age. And that's really captured in this idea of frailty. So frailty is defined as the physiological reserve that an individual person or patient has to external stressors. For many of us, it is the representative clinical construct of what we call the biological aging process. Frailty is not synonymous with age, and that's really important. It's closely associated with age. The older you get, the more likely you are to develop frailty, but it's not necessarily the same. So these are two sort of exaggerated but very common examples that are used. Ed Whitlock running a marathon at 90 years of age is different from the patient who's 50 years old with end-stage COPD on home oxygen and who's wheelchair bound. Now, we consider that at the bedside, but we don't measure it and we don't include it in studies. But we have that inherent understanding that not all 80-year-olds are the same, not all 50-year-olds are the same. And I would challenge you that future data really needs to capture frailty. And how do you capture it? Well, the tool that is most commonly used is the clinical frailty scale. This is actually developed in Canada. And it scores patients from 1 to 9 on their degree of frailty. And you'll notice that age has nothing to do with it. And what they actually consider is the patient's functioning and their dependence. So how much your baseline level of functioning, how fit you are, and how dependent you are will determine your degree of frailty. And you'd probably not be surprised if you don't already know that frailty is strongly associated with outcomes after critical illness. This systematic review by John Muscaderi been cited, I think, 600 times or so since its publication in 2017. shows very clearly that mortality in ICU is associated with frailty, independent of age. And that includes both short-term and long-term mortality associated with increasing frailty. Work from our group, which is a few years old now as well, looking at frailty and its association with mechanical ventilation. So if you're frail, and you're mechanically ventilated, not only are you more likely to die, you're actually more likely to experience extubation failure and more likely to receive tracheostomy. And you can see this graph showing the percentage of patients still on mechanical ventilation, comparing the patients with and without frailty. The patients with frailty still on mechanical ventilation. And it might not be that it's not that exaggerated of a difference, but also remember that this doesn't account for competing risk of death. So frail patients are more likely to die earlier. But you can see even at 10 days, 11 days, the frail patients with frailty who survive are still more likely to be vented. Unfortunately, when it comes to ECMO, there's very, very little data that exists on the association between frailty and patients receiving ECMO. And understanding and quantifying this is extremely important for incorporation into decision instruments. And that's what I think is an important thing to take home. You know, I think probably most of us would say patients with substantial frailty probably don't go on ECMO at most centers. But it would be important for us to know what proportion of those patients go on and you know, what that association is with outcome. I suspect, and I think as many of you do, that it's associated with worse outcomes, and it might be more exaggerated than age itself. And therefore, that may be the better variable to consider in selection. But a lot of conjecture and not a lot of data on my part, and hopefully this will be something that gets studied in the near future. So in conclusion, identifying patients that are the most appropriate for ECMO is beneficial, not just for patients, because it optimizes their outcome, but it's also beneficial, I challenge you, for the system. So we can optimize cost and resource use in the use of this technology. The existing tools, whether you're using them or not, you should know they have only moderate accuracy for prediction of outcome. And therefore, many would say that newer tools are necessary. Age is a salient prognostic factor among patients receiving ECMO, but also remember that the association occurs very early, as early as 30 to 40 years in patients on VA and VV ECMO. Age should be strongly considered, therefore, in decisions related to provision of ECMO or cessation of ECMO. Do I stop ECMO in this patient who's not necessarily doing well? But weren't able to identify an upper threshold of futility. Mind you, the definition of futility is variable. And some might say an odds ratio of 8 or 9 in patients greater than 80 is pretty substantial. But I also would challenge you to think that the association between age and outcomes might actually represent the construct of frailty. And we really need more data in this regard. So with that, I thank you again for the opportunity to present to EuroELSO. What a privilege it is to be a part of this webinar. My information is below, including my email and my X account. And so feel free to contact me or tweet at me if any more questions arise. But again, thank you so much for the privilege of doing this.
Thank you, Shannon, for your excellent presentation. I really admire your studies here, the very clean analysis based on the EuroELSO registry data, and the way you discuss your findings, and also the considerations you have with respect to what we not know, especially with the point on frailty. And I very much agree with that. And maybe this is something we can discuss a little bit. And I don't know what the selection criteria in your center is with respect to age limit, but let me just give you what we experienced during COVID. That was the first time that we really had to come up with some rather strict criteria concerning contraindications, because we just didn't know what would come up to us. And even knowing that in some countries where COVID already had been a larger topic, we decided to be a bit more liberal with respect to the age limit. And I have to say that our selection criteria over the course of the pandemic served as well in terms of being able of keeping up with the demand and the resources. And we cannulated elderly patients, and something that my feeling was that it's kind of part of our culture that if we have patients that are in single organ failure, we give them a long time to recover. This is something that many of us seen during H1N1, that some of the lungs need 2 or 3 months, right? So even the elderly patients, we would not take any decisions to withdraw the care as long as they would not have any additional issues. My feeling is that many of them who would have crossed 70 years of age, maybe, even they technically stayed in sort of a one organ failure, sooner or later they are prone to run into, I would say, non-ECMO medical complications, right? That's probably something you couldn't look at in your analysis, right? You rather looked at the rather ECMO related complications. Is that something that you see in your clinical practice, that these maybe concealed comorbidities somehow pop up then in terms of some issues, like in only be it, let's say, atrial fibrillation, something like that? What's your feeling about that? Or in other terms, why is age associated with outcome?
Yeah, and I
From
think
what you have mentioned already.
Yeah, first, Peter, I think you're drawing to mind the pandemic is a great place to start, because that was an extreme example of high volume of patients, but also very limited resources. In Toronto, in Canada, in Toronto, we were so overwhelmed in the Toronto region that we were shipping patients out of the region to other parts of the province, and that's, ECMO or not. And so our primary ECMO center, Eddie Fan Center, Toronto General Hospital, was very, very overwhelmed at many points during the pandemic, and in fact had one ICU dedicated purely to ECMO, is my understanding. And he and their group are probably better to versed on discussing how the pandemic influenced their selection criteria. But I think at the same time, they wanted to give patients as much of a chance as possible. And other ECMO sites in our province were doing similar things, but we're restricted by resources. So I think, that's a challenge that hopefully, knock on wood, we don't see again in our lifetimes. But it really brings to mind the challenges of selection when you're under such duress. What I would say is the data of elderly patients in ICU very clearly shows that elderly patients are at risk of increased ICU complications, of course, like regardless. So higher association between age and VAP, for example, higher association between age and venous thromboembolism, for example. And so, yes, I think that it's certainly true that exists. Why such age and senescence are associated with those type of complications is unclear. Is it related to immune functioning as you age and therefore higher association of that? Probably to some degree. As patients age, and I think this is whether this occurs with or without underlying frailty, I think there's underlying dysfunction of systems and organs regardless. So I think you're certainly right in saying that, I don't practice at primary ECMO center, but I think you're right in saying that any patient, whether they're in an ICU on inotropes or vasopressors, whether in the ICU on mechanical ventilation, or then the ICU on ECMO, I usually do inform families that the risk of them developing a complication outside of the principal reason that they ended up in ICU is higher. I certainly think that probably mediates the association between age. I think you're right to say that. I don't have substantial data in the ECMO population. As you mentioned, the EuroELSO Registry really focused on ECMO, or captures ECMO-associated outcomes. And so ECMO-associated complications, I should say. And therefore, we have less data on how, those things that cropped up, right? Once the patient has single system organ failure, exactly like you said, or the reason that they came into the hospital, once you start developing complications on top of that, they have a large VTE now, you have to anticoagulate them, and ECMO, obviously that's happening anyway, but they've developed a VAP, and now you can't get them off mechanical ventilation very easily. The degree of neuromuscular weakness that occurs in these patients is more pronounced than a younger patient. So the way that they deteriorate from a neuromuscular perspective is much higher. I think that is probably very well associated with underlying frailty. But certainly, I think that those things mediate the association between age and outcomes. And I think those represent really significant and important areas for future work. And I think, for the future tools of decision instruments in ICU, not just for ECMO, will account for those things in a greater detail than what we currently have. And whether those are AI generated models or whatnot, I think time will tell. But I think certainly now that we're understanding the granularity of these associations to a greater degree, they will play an important role in decision making at the bedside. And I think that's exciting and better for patients, of course.
Right. So I think your data also clearly shows that there is a need to understand those part of the population who have high odds ratios to better understand what are the predisposing factors, or if we can even find out what the predisposing factors would be to better inform patients and families of risks and chances of ECMO therapy, and maybe adapt our practice to that. Now, the point of frailty, where we don't really have limited data, but that could be really helpful in the future. Are you aware of any projects that would further go into that?
I'm not aware of any specifically. And the problem with studying frailty in general is there's a variety of different indices that people use to quantify frailty. Dan McIsaac, who is the senior author on, or co-senior author on these two papers, has led a lot of this work in the perioperative population, understanding fitness for surgery, for example. He would comment that there's a large number of different tools that are used to quantify frailty. The CFS is probably the best known and best applied. But when it comes to ECMO, unless you're collecting that data prospectively, it becomes very difficult to do that. And that's certainly not true in the EuroELSO registry. So there are methods, I think, for us to apply sort of other indices or sort of estimate frailty indices from the existing data in EuroELSO registries. And Dan has done a lot of that work. Right now, it's not imminently being planned, but I think it's an interesting area. The challenge of it is, I think inherently, most people would say patients with, we account for frailty, I think, when we make decisions related to, provision of various critical care interventions. We're not just purely looking at the age on the chart. We're looking at the patient in front of us, their comorbidities, their level of functioning, their cognitive function. We're thinking of those things. And so we're, making decisions on that basis, but not quantifying the frailty. We're not writing it in the chart, well, they have a CFS score of 6, therefore I'm not offering, this level of support. So I think our decisions as they are right now account for frailty, and that's an inherent challenge because it biases the cohorts that exist. So the patients that are already on ECMO are probably do not have substantial underlying frailty. But that being said, there probably are places where those patients are being put on ECMO to some degree, and understanding their outcomes might be the most valuable. Because if we already know, if among the patients that are selected with underlying frailty, those patients are doing poorly, then perhaps that should be the primary consideration that we take into account when we make decisions with regard to providing ECMO and perhaps stopping ECMO in patients who are already on it.
Right. And you also picked up on a point which I think is really important whenever we talk about doing research on outcome in these, especially patients who are at such a high risk of dying, is that we should, if we ever have the chance to go into this more deeply, we also need to collect data on withdrawal. Which you limited as a limitation in your trial, because as you said, naturally these people will be more likely to have a withdrawal decision. So sometimes it's not really hard to understand why people die, right? Because of the association of age with the complication, or because of assumptions and decisions that are being taken, right?
Absolutely. And those decisions, consciously or subconsciously, are influenced by a lot of factors that are patient related for sure, also potentially systems related, also potentially related to values that physicians might have or patients might have. So very, very complex decisions that are made. And sometimes, our bias is inherently to withdraw life support on patients who are older. That certainly would bias us in this population. And I think that that's an important thing to consider, that perhaps the association is premature withdrawal life support. That was something that was really an issue in research in intracerebral hemorrhage, for example, where it used to be, if you look at the prevalence of intracerebral hemorrhage and withdrawal life support, hypoxemic brain injury after cardiac arrest is another good example, where the pendulum has swung from withdrawing life support very early to now waiting out and seeing these patients actually have reasonable outcomes, which is terrifying because it reminds us of all the patients that had life support withdrawn early. So it's really hard to quantify and account for that. And other than, just providing time and waiting to see. And like I said, this is a challenging area where it's, the costs and the resource use associated with ECMO don't always afford us that opportunity. So I don't know how you get around this. And I think it just reflects the reality of medicine as it's practiced worldwide. It's just something that I think is important for us to account for, that likely these patients are having life support and withdrawn earlier.
Excellent, Shannon. So if our participants still want to ask any questions, please feel free to still type in some of them. Also, if you want to share some of your practice, how you approach it, that would be more or less the final moment where you can post something. Yeah, I think there's much more to learn, even though we learn a lot from your studies, particularly the point that the odds ratio goes up very, very early, and you could also use that any way you want it, because if some of us may say, well, odds ratios in really elderly patients are so high, but then the next colleague may come around and say, well, yeah, but if you're 50, you already have a markedly lower chance of survival than other patients, and that would apply especially when it comes down to the resource issue. So yeah, at this point, I would like to thank you very much again, mostly for doing the work. I think it's been terrific, and congratulations to you and your group, and also to mention all the people who put in the data worldwide, and most of our participants are really contributing. Thank you so much for doing that. We're learning so much from the EuroELSO registry. It's a valuable tool, and we can have very nice webinars with them. So
yeah,
Shannon,
I really appreciate it, Peter. Thank you so much for the opportunity to be here and present.
Excellent. So I hope to see you around with either with fresh data or you know, at a meeting, and stay with it. Thank you so much for being so motivated, Shannon. It's really inspiring. And
thank you so much for having me. And again, thank you to everybody who records data in the EuroELSO registry. What a valuable and tool we're fortunate to work with.
Absolutely. So with that, we're close to closing the session. I would like to remind all of you that Krakow in Poland is the place where we have the next annual meeting, April 24, 27. I guess that most of you who will come already have arranged everything, but if you are still undecided, this is a strong recommendation to come. It's a great city. It's a great program. There's a lot of speakers that EuroELSO people, very easy to approach. So there's a lot of space to have discussions at the site, and to come together as a community and to profit from each other. So please come and support the EuroELSO and ECMO movement. And with that, I would like also to thank our audience for joining today, and be reminded that this is recorded and can be reviewed in a couple of days on the website. And last but not least, remember, you're only safe if your venous line is blueberry and your arterial line is cherryberry. Goodbye from Vienna, and thank you to Canada.